Hi everyone, this is Dr. Aurelie Najm from Glasgow reporting live for now in Japan. I'm in Fukuoka. It's been about 37, 38 degrees Celsius, so really warm over the past few days. But it's also been really great to see a lot of the science that's been presented. And if you know me, you know that I have a particular interest for interstitial lung disease. And so there was this really good session earlier today looking into interstitial lung disease across connective tissue diseases. And so there was a lot of discussions around stratified medicine and are we there yet? I would not use the word personalized medicine because I think we're still further away from there. But there was a lot of data presented looking at stratifying patients and treating them accordingly. And I thought that was quite interesting. So the first thing that was discussed was the screening, and when it comes to CTD patients, how often do they need to be screened systematically for ILD, or do we keep that for those patients that have phenotypes of disease that are more likely to evolve into interstitial lung disease? And so there was a discussion in particular for systemic sclerosis. And while the ACR recommendation back in 2024 were recommending to screen people with systemic sclerosis only when they have factors of high risk or poor prognosis, it was actually researched that doing this sort of screening is at risk of missing 1/4 of systemic sclerosis patients with ILD, which is quite a lot. And in fact, the new guidelines from ESR, so the European Society of Respiratory Society, and EULA recommendation were published 3 days ago. And were discussed. And so now the screening in systemic sclerosis is recommended for basically each and every systemic sclerosis patients. And so that was the first thing around screening, and what's recommended for the screening remains the chest HRCT, as well as the pulmonary function test, while the lung ultrasound in these recommendations in particular is not recommended. So HRCT is still the gold standard there. Now, the other thing that I found quite interesting is the progression. It turns out that the progression of ILD can be severe, and it's sometimes actually it also can be fast, and it's also sometimes really hard to predict which patients are going to be fast, rapid progressors. And while the progression criteria haven't been revised in the past few years, it's either the inbuilt criteria, so a decline in FCV, worsening of symptoms, or increasing of fibrosis on imaging, and the PPF is pretty similar. There's still a huge heterogeneity, and in particular, one study was presented looking at systemic sclerosis, and they were able to cluster patients based on their autoantibody profile and clinical features. And there were actually 3 different groups. And it was really interesting in particular because this was a study that was discussed where actually a patient that progresses at one visit is not more likely to be progressing at the next visit. So it feels that progression, in particular, at least in systemic sclerosis ILD, is kind of like short burst phenomenon progression, and then maybe no progression for another 3 years, or maybe a yearly progression. So the clusters that were identified in the study were a more kind of diffuse systemic sclerosis with SCL70 antibodies, severe vascular manifestation in periphery, and these patients were more likely to progress and to progress rapidly. Then you had another cluster with usually a later age of onset for the disease, anticentromere antibodies, more limited systemic sclerosis, no renal crisis, less ILD at diagnosis, and these guys were more stable or unlikely to develop or progress. And then you had a third cluster, which was more this kind of overlapping forms with positive RNP antibodies, younger age of onset, more often pulmonary hypertension, myositis, and so on. And obviously this cluster was also at risk. However, because obviously there is a but here. These three clusters were still overlapping quite majorly, and so the risk by following this clusterization to support earlier or more aggressive treatment is to overtreat. And so in that context, it was also recommended to obviously treat this with while being careful, and maybe that definitely warrants more trials, and in particular stratification based trial, which we desperately need. I will do a specific report on the updates on the treatment from the new guidelines. So stay tuned for that. Follow me on Twitter at Aurelie Najm, and follow Rum Now for more content. I'll see you later.